Good afternoon, good morning, everybody. My name is Dr. Enha Wu from Oregon Health and Science University. I'll be on behalf of the Education Committee to start with today's webinar. So welcome to July 2025 Curious Case webinar. These webinars are meant to be informal and interactive. So feel free to respond to my question and ask your own if you have any. And then feel free to jump in, give some comments and thoughts, and share your thoughts and then ideas about the cases I'm going to show. Great, it was great to see everybody, and then we'll get started. Hope everyone can see my screen okay. Okay, all right. So first off, disclosure, there's a little bit of image product from the cloud-based assistant AI-assisted analysis company, Heartflow, in the coronary cases. But I don't have any financial relationship with them. All right, so today's cases, we're gonna start with a cardiac CT, MRI, and then there's a coronary CTA and a structural CT. All right, great to see everybody. So this is the first case, 32 years old, had a URI symptom, sudden acuity of the symptom, worsening of the shortness of breath. The echo showing reduced LV systolic function. Let me start with SFFP to look at the morphology first. All right. To give you some orientation, 2, 3, 4 chambers and short X's in the bottom right. I don't know how to make the recurrent playing, but I just keep playing. Feel free to jump in and say what you see to here. Otherwise, I will say something, say findings out here. Just pause 10 seconds. Great. Here's some of them talking about the findings here. Yes, we see there's a severe hypokinetic movement, and then there's no thinning or hypertrophy. As you can see, there's a nearly global severe hypokinesis. As we see, the septum is mostly get involved. As you see, it's not really contracted in. To me, it's like very severely hypokinetic over the septal walls. All right, next is the flow. The flow curve looks pretty good. It's only minimal regurgitation, 3% regurgitation fraction. The SHORX, the function analysis showing the severe reduced LVEF. LVEF is 13%, which is correspond to what we're seeing on the CINI. So for those, just jump in. Feel free to share your thoughts and then comments on those cases. The cases we're looking at is a person have severe reduced function, and the CINI image is showing the severe reduced motion normality, particularly over the septal walls. Well, we're very lucky to have some tissue characterization. This is T1. So our T1 native cutoff in our MR setting is around actually around 1050 milliseconds. So this is a kind of borderline or slight increase of negative T1 when we put in a regional of interest in the septal walls that's showing the 1069 milliseconds. And the ECV based on the hematocrit is 0.47 is 25%, which is normal. All right, let's look at the PSIR. Again, I put in 2, 3, 4 chambers, and the bottom right is the show axis. Let me pause a little bit here, 10 seconds, and let me know what are you seeing. Great. I hear some of them talking about LGE. That's correct. So what we see here is in the two-chamber view, as you can see, base to mid-ventricle, inferior wall, there is this transmural or focal areas of a LGE is right here. As you can see, this is pubic muscle being kind of questionable involved or just elevated. I'm not sure. And then there's short axis right here. It's a corresponding what we see in the mid-ventricle levels As you can see, there's a involved near the entire myocardium. Actually, I would say entire myocardium, and also a little bit white based when we come to toward the subepicardial layer. All right, so next question you're gonna be asked very often is, what's a pattern? This is ischemic, non-ischemic, non-specific, or you call it normal. This is non-specific, it's nothing particular. Again, this is a severe reduced LV function, 30% LVEF, severe motion abnormality, for those who just jump on. And what do you think is ischemic? Is ischemic or non-ischemic or non-specific? I know it's kind of, sometimes it's not really have a clear cut what we see. Okay, let me see what's exactly, is anything right here. Do we have any chat? Okay, nothing yet. Great, excellent. But I heard somebody talking about ischemic, and then someone said non-ischemic. Alrighty. So what's the diagnosis? The patient had a URI symptom of a few days ago and then worsening of heart function. So this turned out to be a myocarditis, and the patient received supportive treatment, like in the T here, and then being discharged smoothly following the treatment. So we're gonna review very quickly about the MR criteria for the myocarditis. T1 base images, basically what we've seen here on this case, is have a non-ischemic pattern of the LGE, and then there's a regional or global increase the DC extracellular volume or native T1. On the T2 images, we're gonna see increase the T2 value. Although we don't have that just here, but if you see the increase T2, that means there's underlying myocardial edema. There's supporting criteria if there's a findings of a pericarditis. There's a regional motion abnormality. Okay. Then we're gonna move on to the next here. This case, I don't have a T2 black blood, just showing the cases. A typical T2 black looks like this, involving the interior lateral wall, continue to the inferior wall. You're gonna see that fast spin echo T2 black blood. This is just another paper just cited this revised criteria for the myocarditis. T2 high signal, elevated T2, increase the high T2 signal value for the myocardium showing myocarditis, T2 edema, and then there's elevated T1, native T1, and the ECV showing the underlying intrinsic fibrosis. And of course, you need to have a LGE pattern, which is non-ischemic. And the supportive criteria are structural dysfunction, which is here we're showing the severe reduced LV function, and then if there is a supported evidence of a pericarditis. So based on what we see here, it's kind of difficult for me. I know some people may raise a question about this may be a focal transmural infarct or ischemic pattern. Sometimes very hard to tell, but when it comes to the information kind of more involved, entire the layers can showing this transmural involvement. But definitely have to correlate with a clinical symptom. But this turned out to be a myocarditis, and then we reviewed the MR criteria for the myocarditis. Question? Nope. If yes, interrupt me anytime, or that we could talk about it by the end of the session. Case number 2. So this is a 52 years old chemotherapy for a metastatic visual organ cancer, and was admitted due to progressive dyspnea. This patient also showing the reduced systolic function on the echo, and the LT valve has echogenic abnormalities. All right, so again, we're gonna look at these scenes for the morphology. Again, this is 2, 3, 4 chambers, and then this is a short axis on the bottom right here. I'm gonna pause it here a little bit, 5 to 10 seconds, and you could look at it, and we could look at that, and then if you have thoughts, just let me know. Again, feel free to jump in and um, give you some comments. Great. I heard some of you talk about that. Exactly. So what we see here, first up, there's no particular areas of myocardial thinning. There's no myocardium hypertrophy, but definitely there's a motion abnormalities. As you can see, it's sometimes very hard to tell exactly which segment has a problem. But when you look at the short axis, when a lot of walls try to contract it in, you see the septal wall is not moving very well. There's severe hypokinesis of the septal wall, anterior septal, inferior septal walls. This is by the mid ventricle levels. The valve, you see here the valvular thickening, and then there is a regurgitation that we've seen in here, and then there's a little bit of acceleration jet over the LT root. Excellent. Now, I changed to this one saying this is a LT valve infarct, but actually this is our routine that our tech like to do RVLT for most of the cases. And unfortunately, at this level, we see this is more like mimicking LT valve infarct view. There's valvular thickening, but the motion, the opening and closure looks fine. There seems to be, incomplete coaptation of the valve leaflets, but definitely you could see some lobulated thickening right here. Excellent. All right, flow quantifications right here. We see here that there is a moderate regurgitation, 35% fraction, and then here on the Q flow, you already can see the valvular thickening right here. See that 3 lift together thickening right here. All right. Functional analysis showing the mild to moderate reduced LV systolic function, EF 39%. In this case, we have a T2. So we basically traced the entire myocardium, so showing that around almost 69 milliseconds T2 value, which is elevated. As you see the curve, it dropped a little bit higher, severe than the normal. This is a T1 mapping. We just draw the areas of interest in the septum. So the native T1 is elevated, is 28 milliseconds. The atrial septal volume is 35%. Elevated, both of them. Great. Now, let's look at the LGE. 2, 3, 4 chambers, and the short axis, bottom right. I'm going to pause 5 to 10 seconds again. Let me know what you think, or if you have any comments, let me know. Yeah, I think I heard some of you guys are saying it's kind of interesting pattern. It is. It's kind of curious pattern, I would say, because everything we said interesting is the patient's suffering. So what we see here, you see there seems to be a transmural, or the involving the septal wall. This is the anterior septal wall. The fourth chamber also involving the septal wall, more like the inferior septal wall. On the short axis view, mid ventricle level, you see this LGE is right here involving entire the layers of the septum, anterior and inferior septal walls. There's a separate areas of subendocardial enhancement right here in the inferior lateral. So corresponding to here, the fourth chamber, we see that a little bit. Short axis probably right here. You see a little bit thinned area. Okay, next $1 million question I'm going to ask you. Not yet. Okay, so short axis. This is a mitral. See the D shape? Mitral level. You see the LG enhancement also involving the LT valve. Remember we talked about LT valve thickening. And this is the areas of LGE. There seems to be some part being uh, spared or reserved out there. But look at the LVOT view. It's involved right here, and $1 million question now. So, what's the pattern of that? Is it a this is a patient with chemotherapy, had to reduce the heart function. We see the LVEF is a 40%, and elevated T1 and T2, and the ECV also, extracellular volume also elevated. So what's pattern is that? Tough one, I know. When I look at that, this is the patient overnight on the weekend, and then we kind of just struggle with what we should say about this to the ICU doc. Then what's the diagnosis? All right. So what we've seen here, this is a large areas of LAD territory infarct. I should put in the figure here as well. And what we see here, this is a large infarct of the septal walls. These areas are the MVO, microvascular occlusion area, the infarct area, no perfusion at all. And there's a separate areas of a subendocardial infarct involving the inferior lateral wall. Let's look at that again. Just right here, this area is non-enhanced area. This is actually not a preserved myocardium. This is an infarcted area that don't have any perfusion. As you can see on LVOT view, this is areas of the MVO. Just keep that in mind. This is MVO. This is a separated infarct areas, circumflex territory. So, and also we see there's LT valve thrombus. We see the LGE, and then there's a moderate regurgitation of the LT valve. So, what are we gonna review very quickly? I hope we have time to go through some of the cases. Maybe I talk too much, but I want to talk about the infarct of on the CMR and then microvascular occlusion thrombus, and raise a question. Chemotherapy can cause the myocardial infarcts? Okay. This is a paper from the Radiology 2021. I think there is very good correlation, very good reference of that. On the left, this is a T2 mapping. As you can see, the T2, I should say, T2 black blood. As you can see, there is a surrounding high signal surrounds those areas of low signals. And corresponding areas on the LGE, as you can see, the LGE surrounds those areas without any enhancements. This is areas of the MVO. This is another areas of MVO right here over the anterior wall, involving the anterior lateral wall, as you can see corresponding areas right here. T2 star is a good pulse sequences to characterize the hemorrhage. But otherwise, you could do the T2, either do T2 black blood or T2 mapping to characterize those, and then just also recognize the MVO areas on the LG PSIR sequences. This is just a review very quickly. Those areas MVOs are damaged and dysfunction of the myocardial microvasculature and the no flow. This happens in the patient with infarct or following reperfusion. Is a marker for a worse prognosis. So now the question: the chemotherapy or myocarditis can cause transmural LGE and MVO? The answer is probably yes. This is an example from the JACC 2019 paper just showing the MVO in the patient with lupus. So here's we see the cores right here, the low signal intensity core and the apical septal wall, as you see on this PSIR pulse sequences, and there's enhancements around the core in the apical septal wall. So it's kind of in between, but based on what we've seen in this case, we call it this is a large territory, LAD territory infarct with MVO, and then likely the separated infarct of the circumflex territory. All right. And we talked about the T1 and T2 mappings already. All right. Question. Okay, we're gonna move on to case number 3. It's a 59 years old, had a viral symptom a month ago, progressive dyspnea, and then insertion, and then orthopnea. So echo, again, showing the ventricular systolic function has reduced. There's an MR and tricuspid regurgitation. As usual, we're gonna look at this morphology first. Oh, for some reason, just playing some music here. Okay, so what we're seeing here, okay. Again, you see motion abnormalities. Seems to be, again, there's a severe hypokinesis of the septal walls. All right. And the flows. Flow looks good. I know there's an interesting trough right here. There's a very mild regurgitation, 5.5% regurgitation. The EF, as we expected, is very low. This is severe reduced EF. LV systolic function EF is 18%, match what we've seen on the cine images. T2, mildly elevated. I would say borderline to mildly elevated, 61 millisecond. As we do the global quantification, there seems to be slightly increased right here than inferior wall. T1 is borderline elevated, 172 millisecond. ECV also mildly elevated. All right, so summary what we have here. The PSIR. I'm gonna pause it right here a little bit. So look at the PSIR images 2, 3, 4 chambers in the short axis. What do you think? Okay. Excellent. Yeah. So what's your diagnosis based on what we see here? Severe reduced LV function. Patient has some infection symptom before, now with severe reduced function. LGE looks like this. There's a mild elevated ECV. There's a mild elevated T1 and T2. And then LGE. Any LGE? No, I don't think so. I don't think there's really a LGE here. So what we're dealing with is a patient had a dilated cardiomyopathy, and then there's no myocardial scarring based on the LGE, but there seems to be a evidence of intrinsic fibrosis given the elevated T1. There's probably borderline to mild myocardial edema. So what should we do? Normally we just, it's basically what we're gonna report, dilated cardiomyopathy but no scarring. So cases like this is kind of just, kind of in between like a borderline or the grayish area, gray zone area. We have elevated showing T1, showing the diffuse myocardial fibrosis, edema or infiltration, but there's no LGE. This can be, some of the papers suggest that elevated T1 can still correlate with the disease severity and prognosis. And also T1 mapping can help to monitor the treatment response, such as in patients with amyloidosis. This is just a look at the T1. The shortened timing of T1 can be seen with gadolinium, of course, the iron deposition. As T1 started elevated, you see the edema, fibrosis, and the patient with the amyloidosis. Same as to the ECV. When you started to see the ECV started increased, you see the patient with dilated cardiomyopathy, infarct, myocarditis, and amyloidosis. It's not a patient. He's looking at the T1 mapping in the patient outcome. It's basically showing, just look at this one, the dilated cardiomyopathy patient, LGE negative, negative T1 elevated. Those patient has a shorter period of time to reach the endpoint. The endpoint here, they're talking about the patient being hospitalized or had a cardiac symptom. And also ECV elevated, their cutoff actually is 25, 26. It's slightly lower than we expected, but they're using that more stringent criteria. Those patients had a symptom earlier than those without elevated ECV. So definitely showing the basically showing the T1 negative T1 and ECV as a marker to say patient's outcome. All right. So summary, what we see here is a patient with dilated cardiomyopathy, no LGE, but elevated T1 and a mild elevated T2. All right. Okay. Case number 4. All right. 75-year-old female coming here is acute congestive heart failure. There's non-ischemic cardiomyopathy diagnosed at the clinic. They did an excellent job over the clinic and refer for the cardiac MRI. Again, we're gonna look at the CNE images. I take the measurements already. This is end diastolic. The measurement of the inferior septal wall is 15 millimeter. Okay, let's look at CNE. Okay, what do you think? Yeah, we see there's a hypertrophy is right here. Borderline increase the myocardium. It seems to be more pronounced over the septum, but pretty symmetric otherwise. Well, I have to say this basically seems to be more involved in the septum. But remember, some of those are actually like, RV trapeculations or RV side of the wall. All right. The function-wise looks fine. It seems to be normal or low normal. There's no definitely the valve abnormalities. Flow looks good. There's minimal regurgitation. Curve looks pretty good of the aorta. The function, as we seen on the CNE, will give the mildly reduced borderline to mild reduced LV function. The LVEF is 50%. All right, let's look at TI Scout. We have not talked about a TI Scout. This is a TI time. TI is 162, and then I really feel like, so allow me to say that we acquired images started from the later time, so we don't have a really early TI, but still, look at that. Basically, the tech using the TI Scout to choose which timing to gnaw the myocardium and acquire the PSIR. But here, it's really hard to tell exactly when the myocardium get gnawed. Yeah, it seems to be get gnawed at the same time with the blood pool. So it's kind of interesting dynamic of the contrast. All right, so given that, the tag then did a PSIR. Here's the thing what we've seen on the PSIR. Again, 2, 3, 4 chambers, and the bottom right is the short axis. What do you think? Yeah, I heard some of those talking about the interesting findings out here. Exactly. So what we're seeing here is pretty extensive, diffuse subendocardial enhancement, and some of them involving almost transmural because involving more than 50% of the myocardium. Yeah, and again, $1 million question for you. Again, what pattern is that? Ischemic, non-ischemic, non-specific? Definitely not normal, but I put in there. Exactly. This is non-ischemic. And what's your diagnosis? Interesting, unusual contrast dynamic on the TI scouts, and then we have this extensive diffuse subendocardial enhancement. See some of the also involved in the atrium as well. Yes, this is a case with showing the amyloidosis. So amyloid basically is an amyloid kind of filled in the myocardium. This fibro deposits is filled in the myocardium has expand the ECV, the atrial volume, and also growth is showing the LV wall thickening. There's a several ways to diagnose that. Is actually a diagnosis need to have multimodality integrated with clinical information, the lab and the imaging to become a this diagnosis. The LGE pattern, what we see here is because the expansion of the extracellular volume and the result because of the amyloid fibril deposition. So what we see here is we're going to see very extensive subendocardial or transmural LGE as we've seen in this case, and also the abnormal Galilean kinetics that we talked about earlier on the TI scales. A lot of time we see the TI, the myocardium and then blood pool get gnawed first, get gnawed at the same time or kind of reverse timing. And also for the patient with amyloid, we see the T1 has increased. Native T1 has increased in ECV, also have this diagnosis ability, utility in diagnosis of the amyloidosis, also the follow up on the treatment response. The T2 relaxation on the amyloid also showing elevated. This is a case actually I used the other one, but amyloid has also can show the T2 increase the T2 value of myocardium, also showing this prognosis relevant on the patient with cardiac amyloidosis. To diagnose amyloidosis, you have to go through this difficult chart right here, stratification and everything, and become a diagnosis right here. But here we're basically showing we just need to look at that on a cardiac MRI as a part of an MR reader. You can get to know this global subendocardial OGE, dark blood pool, signal intensity, and the elevated T1 and ECV. Questions? Great. Let's move on to the case number 5. So this is a 68 years old, had a systolic heart failure and the history of a atrial fibrillation. All right, so we're gonna look at the CINI again. Let's do that. This image is not so great, I understand. We did our best. The patient has a arrhythmia. You see the defibrillator or the pacer in the atrium, right atrium, is also extended to the right ventricle, as you can see here. The image looks a little bit fuzzy, but contractility-wise, motion of normality seems to be low normal. The contraction so far so fine. There's no particular areas of hypertrophy, no focal areas of myocardial thinning. All right. Flow looks good. Very minimal regurgitation. Function is low normal or just normal, 55% LVEF. All right. TI scalp again. Okay, this time we acquired pretty early. You see, they started acquired a very early time, and then what? So what do you think? Let me recap that. Myocardium get gnawed first, and followed by the blood pool. Yeah, I think it's showing it again. Myocardium get gnawed, followed by blood pool. Is that normal? This is unusual. Yeah, because suppose we're gonna see the blood pool get gnawed first, and followed by the myocardium. This is kind of reverse again. So I'm thinking maybe, oh man, we were looking at the same type of a disease again. This is possibly amyloidosis. So I told the tech, well, okay, the timing you're gonna choose is the one when you see the myocardium get gnawed. Use that TI to do the PSIR. And the tech will say, okay. And so Uh, But before that, they also did the T1 native. T1 native is kind of normal. It's upper normal, borderline. Well, I would say normal. 1052, and ECV is normal, 26%. And so they give a contrast, and I got a call back very quickly saying, well, you know what? When we give the contrast, patient feel like a little bit something like fluid over her arm. It looks like there's no contrast in there. So what do we see here in the previous TI scout is actually without IV contrast. I say, oh, that's why we see the myocardium getting off first and follow by Bob Wool. And so I say, well, make sure we got a contrast in and let's do the TI scout again. So here's the TI scout after the contrast was in. Let's play the scene. Did that? Myocardium get gnawed, following the Bob Pool. Let's do it again. Bob Pool and the myocardium. This is normal. The patient is normal, had a normal TI scout, which is book locker sequences. Okay, based on that, they choose the correct TI and did this PSAR, which everything's normal. See the very dark, simple dark myocardium, no LGE at all. So we report this is normal. There's nothing, just low normal LVEF 54.5%. So just quick review the TI. Inversion time, this when you have a inversion recovery sequences, you give a reverse pause, and the myocardium get not at this timing. Normally is a 250 to 300 millisecond based on your scanner and then settings. And then the abnormal areas where it's infarct or the information had high signal. This is the time we do the PSIR. Okay, so again, approximately 300 millisecond for the TI on the 1.5 Tesla scanner, and make sure you got a contrast in. Otherwise, you're gonna have a very interesting dynamics of the contrast, kinetics of the contrast. All right, lesson learned. Actually, pretty good, great. So summary, what we see in the CMR, we do morphology analysis, LG pattern, and then we learn the T1 and T2 characterization on the myocarditis, and then some of the findings before. Excellent. Now, before we move on, any question, any thoughts? Great. We gotta move on to the second half of the section. I see we still have 20 minutes. I hope we could go through some of the cases here. Okay, we're gonna move on to the coronary CTA. This is a 65 years old, had dyspnea on exertion, positive for ischemia on the stress test. The previous calcium score is 225. All right, for the coronary CTA, I'm going to give you the axial images very quickly. I know it's kind of eye test, but no worry, I'll give you some hints right here. As I pause right here, you see the RCA, proximal to mid. We'll go back again. Right here, calcified. Yes. All right. So what we see here is there's a calcified plaque over the proximal to mid RCA. All right. Let's see that again very quickly. Right here. Excellent. Then we did a double oblique orthogonal plan for the coronary CTA. Here's the thing. Long axis, long axis, and this is short axis right here. So you see the calcified plaques around the wall, and then there's a nearly, I would say, moderate stenosis right here, about 50% luminal narrowing of stenosis of the RCA and the right AV group. Yeah. Then we have this curved MPR. The software did an excellent job. So we can save some time to look at the rotation of this curved MPR images. Let me play the scene. All right. So when you rotate it through, it actually not wasn't that bad. Yeah, it's actually mostly are still kind of along the wall. I do not see a really significant remodeling, but it's kind of interesting. Okay, but on the other view, we say the approximately 50% um, luminal narrowing. All right, so difficult question for you, stenosis. What's your grading on this? What the category? All right, definitely not zero, not minimal, not what, not moderate, not severe, not occlusion. What would say mild to moderate because they're kind of approaching the 50% stenosis of the RCA. We're very lucky to have a AI assisted cloud computing data source for us. We send images to them, and then they come back. They give generate the result, give it back the result very quickly. So this is a roadmap. This is a looking at the coronary lumen out there. So generate the also highlighted areas of stenosis. So the result match what we see here is to have a 50% luminal narrowing, moderate stenosis of the RCI we talk about right there. So you can see the marks right here. So save you a lot of sometimes if you couldn't recognize it or just serve as a second eye, second pairs of eyes to help you to recognize the lesion. So this is a breakup. So you see the RCS right here, calcified plaques have the 50% luminal narrowing. And we're also very lucky because we're just wondering if that's causing any flow limiting or the significant decrease of gradient. So we send it for FFRCT. So turn out, what do you think? This is normal. Yeah, because the distal RCA, as you can see, the lesion we seen earlier is 50%. The luminal narrowing distal of it is FFRCT is still above the normal cutoff. This is a 0.90 normal. And then they put in a color saying, well, this is normal. Green light, blue light, everything is normal. So approximately 50% stenosis, no flow limiting stenosis, FFRCT normal. Okay, so FFRCT is a ready to use, non-invasive alternative to functional assessment of coronary CTA, coronary stenosis for management of patient has a CID. AHA class 2A recommended for the evaluation of lesion with 40 to 90% of stenosis, but actually we a lot of time using possibly 30 to 70% of the stenosis. I think it's 90% when you see this high-grade stenosis where nearly complete occlusion. Basically, it's a patient need a cath rather than do a FFRCT. So FFRCT also refine the pretest risk assessment, guiding the decision on the invasive test. Here means the cath. Some advantages and disadvantages. Advantage is there's no additional contrast, no additional radiation, and could assess a lesion-specific ischemia, and then prevent invasive procedure, and also determine the physiological pattern of disease and pressure gradient. Disadvantages, of course, this need extra cost for that, and reimbursement can be a problem, yes. But also highly depends on the image quality. We, from time to time, we still have the study bouncing back saying, well, there cannot be, the assessment cannot be proceeded because the image quality is not qualified for their assessment. And also there's could be less reliable due to the extensive calcifications. Offline analysis, yes, it might take a little bit of time if this is super urgent cases you don't want to send it for FFR because it may not come back immediately. It may take a 1 to 2 hours to get a result back, but definitely this will be improved in short time, I believe. Just very quick the graph to remind how we read the FFR. Everything is normal when you FFRCT is value from 1 to 0.8. Starting from this point, it would be borderline. 0.8 to 0.76 is borderline. You need to check with a clinical symptom or let them know these findings, and then let a clinician to decide, cardiology decide this should they stratify the patient to do further tests or not. Anything below the 0.76 is positive for gradient decreased. All right. Case number 7. This is a 65-year-old female. The previous has a calcium score 250. There's no definite cardiac symptom, but she's here for the screening. Let me scroll through this best diastolic phased axial, but no worries. We'll focus on the area we're gonna look at it. Distally looks good. Just follow the OAD right here. You see that right here. Yes, exactly. The focal calcified plaque right here. Okay. Otherwise, it looks pretty good. So then we can using the double oblique technique to look at that. On the right two panels, this is a long axis. You kind of see along the anterior wall here. Okay. And this is that. I know this is some of you may say this is a crappy, but this is the best we can get for this patient. We did it actually on the dual source CT, and then this is a fourth third generation of dual sources, which is have very good temporal resolution, but still is sometimes very difficult to see the details, such as patient like this, and then the coronary artery wasn't that dilated at this point, even though we give the patient with a nitro. So it's kind of difficult. Yeah. Okay. Then we're gonna did the other method to look at the vessel. This vessel walk through, just follow the vessel and then rotate it through. This is the area that we're interested in. You see that? We just basically just rotate it through, rotate. Yeah, to me it still seems to be like approaching 50%. In mild to moderate, I would say approaching 50% when I rotate it through. I still can see that on the short axis I've seen in the previous slides. It's slightly more than 50%. Yeah, so it's kind of difficult. And then patient here for the screening, you definitely wouldn't let it go like this. Okay. What's your thought on the diagnosis, stenosis? Okay, definitely not a 0, not minimal. They're probably not a severe, not occlusion at all. So it's kind of still falling in this category. I try to put in some, gray zone area for you guys, but because this is the thing we've been dealing with daily. If there's a severe stenosis, I think a very clear cut. You don't need to, is very clear. But this cases like this, something take a little while to figure this out. Yeah, what do you think? Okay, yeah, I heard some of you talk about that, and then also we sent this for the plaque analysis, showing the very small amount of a plaque right here. The total plaque volume is 56. This patient is 65 years old. 56 is actually here. The patient is a very low percentile for her plaque, very low. But again, the roadmap showing this similar to what we've seen here is like moderate stenosis secondary to the calcified plaque in the proximal OAD. Yeah. And so to further figure this out, we also send an FFRCT analysis. So what do you think? It's kind of, yeah. What should we report on this? When I look at that, I don't feel 100% satisfied because it's kind of dropped to the yellowish area in the distally, and then we wanted to know the areas of this stenosis. This area is causing any pressure drop? slightly, somewhat, but not significant. But can you quantify it? Yes. Get onto the so I further look into the data. So we pointed some of the areas before 1 to 2 centimeter before the stenosis. The FFR we see here is 0.95, and after the lesion is 0.90. That means the delta, the gradient crossing through the lesion is only 0.05, which is within normal range. And distally, before that, they pointed out 0.85 and point little bit further down, 0.8. Very distal segment, 0.8. Within normal range, but I know some say this is kind of gray zone areas already. Yes. Okay. Again, your gradient is 0.05. Well, there's a typo here. I will change that. 0.05. And the distal is what? 0.8. Low normal. So what? The lesion does not cause significant pressure drops. But distally is kind of borderline or low normal. This is the bottom line of this message. The pressure gradient across the corneal stenosis, also known as delta, provides additional functional insight beyond the binary CTFFR threshold, particularly in those patients with intermediate lesions. The cases we talk about here, like intermediate lesions, sometimes just very, what should I do with that? But also look at the delta. KRAS 2.0 suggests that if you may consider invasive angiography for lesion with a significant delta, which is more than 0.12. Our case is 0.05. So those patients will have if the delta is more than 0.12, then those are higher risk areas. So KRAS 2.0 suggests that if you see this, suggest further procedure, invasive procedure. Some other paper using the 0.13, so just keep that in mind, either 0.12 to 0.13 as your cutoff for the delta. And also, again, this paper suggests that delta improved discrimination of the patient underwent early revascularization compared to the standard CCTA with FR, particularly with those intermediate risk patients. Again, 0.12 to 0.13 is for the delta. Okay, I hope we have one more. We have time for one more case. Case number 8. This is a 62 years old, had renal failure, coronary screening before the transplant. All right, we're gonna scroll through the axial images again. No worries, again, this is not eye test. I'll point out the area. We're gonna look at it. This is a proximal RCA. See here in the right AV groove here. Okay, we're gonna look at that again on an axial, not an eye test. Again, moderate stenosis secondary to mixed calcified, non-calcified plaque right here. See that? And then we're gonna look at that on the orthogonal view. This is a long axis. You see the focal short segmental, the slightly expansile plaque with some of the calcified densities periphery, as you can see here. Remodeling, see the pluming of the vessel wall, pluming out, and you see the low density, the plaque surrounded by capped by the calcified plaque right there. What do you think? Moderate stenosis has this, and we have some of it because we acquired at the very short period of the diastolic phase, so I can reformat it into the cine images right here. You see that? Yes, and then short long axis right here. Yeah, so you see the plaque right here causing moderate stenosis and has mixed calcified, non-calcified plaques. All right. curved MPR just for your pressure, ice pressure, for you to look at that again. You see that low attenuation plaque right here, and then there are some calcifications. What? Stenosis. Okay, we all know this is moderate stenosis over the proximal RCA. This area is in the right AV groove. The road map, the map, the AI company, the cloud-based computing company sent us match what we've seen here. Segmental narrowing here is a moderate stenosis, but didn't say which kind of a plaque right there. So we still need our judgment to look at that. So there's high risk features, what? Remodeling, and then there's a non-calcified plaque surrounded by the high attenuation plaque. Let's look at that again. Right here, remodeling, low attenuation surrounded by high attenuation plaques. Just keep that in mind. Those are the high risk. So review very quickly a high risk plaque from the Jack paper 2014. It's decades ago, but still very helpful. Remodeling right here, low attenuation plaque, and then napkin ring side, low attenuation surrounded by the slightly high signal intensity, high densities plaque, and then also there is some spotty calcification within the softy non-calcified plaque. So just remember these 4 features of the high risk plaque. Okay, I think we could pause right here. Very happy to. It's my honor and pleasure to showing the cases right here. I also looking forward to do another one for the rest of the cases, but for the time, it's approaching 11 o'clock from my time zone here. I want to see if anyone have a question or some feedback or comments on those cases that we've seen today. Because I've been heard some of you giving some comments. I appreciate that. And today, what we've seen, let me summarize very quickly. We've been seeing the cases cardiac MRI. We look at the morphology. We're using the T1, T2. Tissue characterization, we look at the non-ischemic pattern and then ischemic pattern on the LGE. And also we review the MVO. And the coronary CTA, we look at the how we look at the coronary CTA, different ways we look at that. And also we review the high risk features. And also we utilize the FFRCT and some of the online computing cloud-based company gives us some more information rather than just eyeball it. All right. Comments, questions?
Thank you, and how?
Yeah. Hey, Shama.
Good. Nice cases. Thank you.
Thank you. It was great to see everybody. I hope you have a very nice rest of the day.
Thank you very much,
too.
Dr. Wu.
Thanks.